Good afternoon, everyone, and welcome. My name is Lucas Brand. I am the Strategic Director of the American Cancer Society's National Prostate Cancer Roundtable, and I'll be your host for today's webinar, in which we're going to be discussing what to do after an abnormal PSA test, thinking about things like MRI, biomarkers, and biopsy and beyond. As leaders in the prostate cancer space, it's obviously critical that we stay current on how to navigate an increasingly complex landscape of prostate cancer detection and follow-up care. So today's webinar is going to explore some of the best practices around interpreting PSA test results, understanding when and how to refer patients to urology, and how tools like MRI and biomarker testing can support optimal biopsy decision-making. We're going to bring together several leading experts from across the care continuum that all deal with PSA test results and the follow-up testing that can support that. Ultimately, the goal here is to help clinicians strengthen their approach to post-screening care and improve outcomes for patients who are at risk for developing or living with prostate cancer. So let's get started. Before we get too far, we obviously want to thank our sponsors, Johnson & Johnson, Pfizer, and Bayer, who have provided generous support for the roundtable, and they make things like today's webinar possible. So thanks to all of these organizations for their continued commitment to advancing prostate cancer awareness. A few ground rules for today's discussion. ACS is a nonpartisan organization. We believe everyone should have a fair, just, and equitable opportunity to prevent, detect, treat, and survive cancer. And so therefore, we're asking that all of our attendees today refrain from any kind of partisan topics or opinionating in the discussion. The discussion today is also being conducted under the National Roundtable's rules for engagement. You can view these rules on our website if you want a full rundown. But basically, the expectation is that everybody treats each other with respect and kindness, with the understanding that we're all here to learn more about how to improve the lives of people who are undergoing testing for prostate cancer, and ultimately maybe those who are going to be diagnosed with prostate cancer. So we're all working toward the same goal here. Last item here is that we are recording this webinar. It'll be made available on our website after we finish today. So please be mindful of the conversation, be respectful of others' privacy, and please do not use any identifying information if certain cases or patient situations are brought up in the discussion. A couple of housekeeping items. Just keep your cameras off during the webinar. If there are accessibility concerns, we will be posting the recording later along with transcript and the slide deck. So this will all be made available after the fact as well. Similarly, please keep your microphones muted throughout the duration of the webinar and just forward any of those questions to us via the chat window or the Q&A pane. Q&A will happen at the end of the webinar. And again, just please remain courteous of your fellow attendees while we are engaging in the chat box and having that discussion. Goals for today include a better understanding of PSA test results, specifically what constitutes an abnormal test result and what factors can influence the variation of PSA scores across demographics and across age groups. Following on that, understanding best practices around providing follow-up care if a PSA test does come back abnormal, and when would be appropriate to refer a patient to urology or follow-up testing. And then finally, what is the role of those follow-up tests in clarifying a PSA test result? Things like MRI, biomarker tests, and how that factors into a decision around referring a patient for a prostate biopsy and trying to minimize the number of unnecessary biopsies that patients are referred for. Quick hello from your ACS National Prostate Cancer Roundtable team. We have our Vice President of the National Roundtables and Coalitions Business Unit, Sarah Schaefer. Yours truly, Luke Brand. I am the Strategic Director of the program, and Nyame Green, our Program Manager, who's done a lot of work and is working behind the scenes during the webinar today. So we appreciate you all for coming and tuning in. We have a brief pre-webinar poll that we'd like you to fill out. 4 questions. This is not a test. You're not expected to know everything. We just want to know where you're coming into this webinar. What's the level of understanding that you have of this topic right now? And then we'll do a post-webinar test as well to see how things have changed and hopefully improved over the course of today's discussion. So now you can pop that poll up here, and we'll give you a couple of minutes to go over it. I'm going to drop off camera for the moment so that you are not distracted by my stunning beauty. I'll be right back. All right, looks like responses are slowing down. If anybody is still taking the pre-webinar poll, please continue to do so if you'd like. Otherwise, we're going to move ahead and introduce you to our speakers and panelists for the day. First up will be Dr. Nyame. He is the vice chair of the ACS National Prostate Cancer Roundtable and an assistant professor at Fred Hutch in Washington. He's a urologic oncologist and a surgeon. His research interests are in health disparities around urologic cancers. He'll be kicking things off today and providing the urologist perspective on this question. Next up will be Dr. Andy Wolf, who is a professor emeritus of medicine at the University of Virginia School of Medicine. Dr. Wolf has 3 decades of experience in the area of cancer early detection and cancer control, with a research interest in doctor-patient decision-making, shared decision-making around cancer screening. He's currently serving as the chair of the ACS Guideline Development Group and will be providing a primary care physician's perspective on today's discussion. Following Dr. Wolf, you'll hear from Dr. Pete Choyke, who is a member of our steering committee at the roundtable. He's a radiologist and chief of the molecular imaging branch at the National Cancer Institute. His work focuses on the development of new imaging technology for the diagnosis and treatment of prostate cancer, including MRI, ultrasound fusion biopsies, PSMA PET scanning, and theranostics. He'll be providing a radiologist perspective on today's discussion. And then finally, you'll hear from Dr. Jeff Tosoian, as an assistant professor and director of the Translational Cancer Research in the Department of Urology at Vanderbilt University Medical Center and the Vanderbilt-Ingram Cancer Center. His research is focused on the development and clinical application of non-invasive tools for early detection and optimal management of prostate and other urologic cancers. He'll be providing a biomarker specialist's perspective on today's discussion. As a reminder, we do have time for questions at the end of today's webinar, so continue to put those questions in the Q&A box so we can discuss them. Last thing that I have for you before I turn it over to Dr. Nyame is a quick overview of disclosures. 3 of our speakers have no disclosures. Dr. Tosoian does have a couple up here, including a role as co-founder and advisor for Links DX Lab, which is involved in the development of biomarker tests for prostate cancer. So with that, I'm going to stop sharing my slides and we'll turn it over to Dr. Nyame for his part of the presentation.
Good afternoon, everybody. My name is Nyame. I'm an associate professor at the University of Washington. Thank you, Luke, for the introduction. I also serve as a vice chair for our prostate cancer roundtable for the American Cancer Society. My disclosures are funding disclosures. And I wanted to give a brief overview of why screening and early detection is important. If you look at data that is published every year for us by the American Cancer Society group, we see that prostate cancer is the leading diagnosis of a cancer in a male in the US, almost 30% of cancers that are detected and almost 300,000 new cases. And it remains the second leading cause of death in the United States from cancer. So 1 in 8 lifetime risk of prostate cancer for an adult male in the US. And when we think about early detection, I think we talk about screening and early detection. If we think about the phenomenon of early detection, it really is a complex process, right? And what we're really trying to do is skip the bottom part of this chart where patients develop symptoms before diagnosis, because symptoms often are associated with advanced stage cancers. And so I think we really have had improvements in how we do early detection from the introduction of PSA into now present day, where we have second line diagnostic tests and tools that allow us to better discriminate who we offer screening to. And the reason for that is, if you think about screening and early detection, really the benefit is mortality reduction and reducing the number of stage 4 cancers that are diagnosed. But the harms are that we detect cancers that wouldn't affect the natural life of a patient, that we overtreat patients who have cancer diagnoses, those that should maybe have observation getting treatments that, and all of our treatments carry with them real side effects. We want to avoid biopsies in patients. The majority of our patients who have elevated PSAs have negative biopsies. And biopsies are not benign, carrying with them up to a 2 or 3% infection rate historically, but there's a risk of other complications that might have patients come back to see us in the clinic. If we really think about screening, we screen a lot of people to benefit the few, which really means we have an opportunity to harm many. So what is an elevated PSA? Well, if you think about PSA, it's a glycoprotein called kallikrein-3, and it's a marker of prostate epithelium, not prostate cancer. Its main function is to liquefy seminal fluid to allow for sperm motility. And it was described in 1981. I found this particular animation to be incredible and took me back to my times in middle school. But 1981 was a long time ago, according to some of my younger trainees, and we really are due for an improvement in a biomarker space, especially with regards to detection. Now, if you look at some of the early publications on PSA, what you see is that the serum concentration of a quote normal population is quite low. So if you look at the 40 to 49 range in that second row, you see that a median PSA is around 0.7, and it's around 1 for 50 to 59, and so on and so forth. And what you see from this early study, which has been corroborated in many studies, is that if we get a PSA test in a male, it should be around 1 or lower. for their first baseline PSA. And the significance of that is that PSAs that are higher, above those thresholds of 1, are increased with a higher risk of having a fatal cancer. And so there's something to be said about really understanding what a normal value is, what a normal PSA value is, and certainly what PSA value should trigger further testing. I think many of us believe in a baseline PSA obtained at a young age. And I would say if you got a PSA in someone between the ages of 40 and 50, and it was far under 1, you really could reduce the amount of screening that you plan to do. And if it was above 1, you could start that counseling process that does take time, and that education around prostate cancer risk and whether to pursue further testing. So the real question is, with so much opportunity to harm many, how can we minimize this harm while maximizing the benefit of PSA-based screening and early detection? And I'm really excited to hear from my peers today who really have great expertise on this topic from the lens of biomarker imaging and a primary care physician. So with that, thank you for your time, and I will hand the talk back over to our MC, Luke.
Thanks, Dr. Nyame. We'll turn things over to Dr. Wolf for his perspective.
Great. Let me get my slides going. Good. Can everybody hear me? Good.
Sounds good. Yeah.
Great. And my slides are up?
Yep, all good on my end.
Great. Well, hello, everyone. And I want to thank Luke and Nyame for inviting me. Again, my role here is that of the primary care physician. And what we can do when we do get an abnormal PSA back. So first of all, the most important thing we can do is to repeat the test. And why is that? Because up to 40% of initially abnormal PSA values return to normal on repeat testing. And why is that? Well, because often there is asymptomatic inflammation causing no symptoms, but raising the PSA. Day-to-day lab variation. Ejaculation can raise the PSA, and even prolonged bike riding. So my general rule of thumb is to repeat the PSA in between 1 and 3 months. The reason being that doing it too soon doesn't give the PSA long enough to normalize if it is due to something like asymptomatic inflammation, which can take a little while to resolve. And if we wait too long, then we are at risk of missing clinically important prostate cancer. Having said that, this is just a rule of thumb, and I think if you have a patient with a marginally elevated PSA, extending that interval out to 6 months for a repeat would be just fine. I do counsel folks to avoid ejaculation or prolonged bike rides for up to 48 hours prior to the repeat test. And this simple step of repeating the test can significantly reduce the number of referrals, unnecessary workups, and even biopsies. Step 2 for most of us is to refer to urology with counseling. Now, when I say most of us, we're going to talk about this during the panel discussion, but there are situations where primary care clinicians may want to consider taking other steps prior to the referral. But for most, and if you're a very busy primary care clinician, which I'm sure many of you are, it is perfectly fine just to initiate a referral after the repeat test. But before they go to urology, patients should know that an elevated PSA does not necessarily mean cancer. About 3/4 of patients with a PSA between 4 and 10 have normal biopsies, meaning false positives, with BPH or benign prostatic hypertrophy being the most common cause of sustained false elevations of the PSA. Second, folks do need to know that if cancer is ultimately diagnosed, it may not need treatment. Gleason grade 6 or Gleason grade group 1 cancers should be followed by the urologist with active surveillance, meaning periodic PSAs, periodic MRIs, and/or periodic biopsies. Finally, if a more aggressive cancer is diagnosed, the urologist will discuss treatment options with the patient. I think folks should also know what to expect with the urology referral. The things that will happen or possibly happen are biomarker testing, meaning a urine or blood test to further refine the patient's risk of having clinically important prostate cancer. They're probably going to get a prostate MRI. And based on these results and the consultation with the urologist, they may be heading towards a biopsy. So with that, we're going to turn our attention to the prostate MRI. And I'm going to hand the microphone over to Pete, who will take it from here.
Thank you, Andrew. Share my slides. Okay, so I'm Pete Choyke. I'm a radiologist at the National Cancer Institute, and we're a place that routinely does a lot of MRIs for patients with high PSA. I'm just showing an example on the left part of the slide of a typical MRI of the prostate. It's for a patient with an elevated PSA, but a negative rectal examination. And you can see it's composed of multiple pulse sequences, a T2 weighted scan, an ADC map, a B2000 or high B value image, and a contrast enhanced scan. And that constitutes a complete MR exam of the prostate. And what it shows, at least the red arrow, is a quite significant lesion that would be impossible to feel on a rectal exam, and was ultimately biopsied and turned out to be a clinically significant prostate cancer, certainly needing some form of therapy. So prostate MRI has become a reflex test for high PSA in many centers. And among large studies, it clearly shows 5 to 10% more significant cancers than just random biopsies alone. So it's certainly worth doing. It's very important because it's not just a diagnostic test, but it's also used to guide the urologist's biopsy using something called a fusion biopsy, where the MR is fused to an ultrasound, and then that is used to guide the needle. Otherwise, the urologist would have no clear idea where the lesion was. I think the MRI can also be used for local staging, and that can be helpful. And it should take about 30 to 45 minutes. There's no irradiation, as you know, and typically most patients can get through it without sedation or anti-anxiolytics. Now, it's important to keep in mind this is not just a pelvic MRI, it's a prostate MRI. It's a very small field of view focused on the prostate. And so it's important that a center that is familiar with doing it does the exam for your patient. In general, we tend to think that it should be ordered by a urologist because they have preferences on where it should be done, and also the results will go directly to the urologist who can act on the findings of the MRI. And for the biopsy, the urologist and radiologist typically work closely together to enable targeted biopsies. So there's more than just a diagnostic test that's read and then biopsy performed, but a second step where there's processing of the imaging. So I think if you know what your urology team likes and where they order their scans from, there's no real problem with a primary care physician ordering an MRI. But it's important to know that if you're not in a system and you're not sure of those preferences, it's probably better to hold off. Now, one term that you'll hear a lot is PIRADS. PIRADS is our system of grading the MRIs. It's important to know that this is not a grade of the cancer. In fact, many of the lesions we detect and label with PIRADS aren't cancers at all, but it's a probability score that there will be a clinically significant prostate cancer at biopsy. So it's sort of a tool to decide whether to biopsy a particular patient or if to do a targeted biopsy of that patient. And PIRADS 4 and 5 are the types of lesions that are highly likely to represent clinically significant cancer, and biopsy is generally recommended. PIRADS 3 is one of these hedge terms that may or may not require biopsy depending on the clinical context. And PIRADS 1 or 2 generally do not require biopsy. Some patients will need sedation. Some patients are too large for MRIs. Those are problems. There are patients, as you know, with renal dysfunction, and we do not have to give gadolinium in those patients. So it's not strictly needed to do a prostate MRI. It's optional. Hip replacements are a big problem for MRI. Rectal gas can cause artifacts, and we typically prep our patients with a Fleet's enema in the morning of the exam or the night before. And there are some lesions that are not detectable on MRI because they're so-called sparse tumors. That is, the tumors and normal tissue are intermixed with each other, and it's impossible to see the lesion on MRI. So there are false negatives, and we're all cognizant of that. Now, increasingly, I hesitate to get off the trail and talk about PSMA PET, but increasingly we are seeing patients arriving with PSMA scans already. And I really want to discourage their use at this stage in the prostate cancer journey. They shouldn't really be used for screening. They're extremely expensive. And if they are to be ordered, should be ordered by either one of the medical specialists, urology, radiation oncology, or medical oncology. They're primarily used for staging high-risk cancers or looking for recurrence or metastatic disease, but shouldn't be used at this stage in the workup. So with that, I'll wrap up and turn the microphone back over to Luke. Thank you.
Thanks so much, Dr. Choyke. Next up, we have Dr. Tosoian to fill us in on biomarker testing for supplementary biomarker testing, let's say.
Yes. Hi, everyone. Good afternoon. I'm Jeff Tosoian. As mentioned, I'm a urologic oncologist here in Nashville, where I practice at Vanderbilt and the Nashville VA. Much of my research has been in prostate cancer biomarkers, so I'm very pleased to be able to discuss those with you. In terms of disclosures, those were mentioned. I did contribute to the development and validation of the My Prostate Score 2 test, and that will be mentioned along with the other guideline-approved biomarkers as I give this overview. And so looking at our NCCN guidelines, here again we see where MRI or biomarkers are offered, and that's in patients with an elevated PSA, where that's been confirmed with a repeat test. For the general population, you can consider 3.0 an elevation meriting consideration of further testing or referral to urology. The most recent guidelines, NCCN guidelines, include specifically these 7 biomarker tests. You see here 4 in red are serum-based tests. An additional 3 in yellow are urine-based tests. And each of these, importantly, have been well validated to improve upon PSA and PSA-based risk calculators for detection of clinically significant cancers. I know we've used that term a couple of times, so I'll just clarify that that really refers to cancers that generally are going to merit treatment as opposed to active surveillance. They're defined as Gleason score 7 or higher, also called grade group 2 or higher. And so those are the 7 available tests included in NCCN guidelines. I will also mention percent free PSA, as I know this can come up for many of you doing the PSA testing on the front line. Free PSA is considered an option by the NCCN. it is well validated to improve upon PSA for for detecting the risk of any prostate cancer. But given that this test was validated in earlier years before we knew that those Gleason 6 grade group 1 cancers were indolent, it doesn't have the level of evidence the newer biomarkers do in terms of predicting risk of clinically significant prostate cancers. I don't personally use it in decision making. If it's available, I may use it in counseling if we have good reason not to proceed with a biopsy in a patient and the free PSA has been ordered. Previously, I may also point out, look, the very high free PSA percentage is another good sign that we don't need to proceed with a biopsy. In my opinion, it's fine to order along with the PSA, also fine not to order. And so here are the aggregate data for those 7 biomarkers I mentioned. This is from a review published last year. And as you can see, the strength of biomarker tests is in their high sensitivity and negative predictive value, making them really optimally used as a rule-out test. Clinically, these metrics, the high sensitivity and specificity around 35%, translate to an ability to rule out upwards of a third of unnecessary MRIs or biopsies, while preserving detection of around 94% of clinically significant cancers. And so here is a listing of those 7 biomarker tests with some pertinent characteristics. These are all currently covered by Medicare, except for the Stockholm 3 test. I believe that evaluation is still ongoing. And coverage by private insurers does vary by insurer and by test. You can see that nearly all of them report on the likelihood of clinically significant prostate cancer as opposed to any cancer, which really is at the focus of current guidelines. 2 of the tests do provide a personalized percentage risk that clinically significant prostate cancer would be detected if that patient were to undergo a biopsy. And so that can be particularly helpful to get a 4% risk of clinically significant disease in Mr. Smith, a 22% risk of clinically significant disease in Mr. Jones, and you can then discuss with them, or the urologist can discuss with them, the pros and cons of proceeding with additional testing. Notably, in recent months to the last couple of years, 2 of the tests, the urine-based tests, are now available for at-home testing, which could aid in workflow. And so some final thoughts. As has been said, there is absolutely nothing wrong with, from the primary care perspective, with simply repeating that PSA test and putting in the referral to urology. For those of you that are interested in going a step further, or perhaps have had a discussion with your urology colleagues about a workflow that you would agree works for the patients, I do think biomarkers provide a strong option, given that they provide an objective result that's not dependent on the person interpreting it, and they can be used to really rather definitively rule out the need for further testing. And so one approach would be to define with a patient that percentage risk of significant cancer below which everyone would be comfortable with deferring further workup. You can obtain a biomarker that has a sufficiently high negative predictive value, or one of the couple that provide the patient's specific risk. If that risk is below the mutual threshold, again, ideally, you've potentially discussed this with your urology colleagues and can all agree if the risk is below 5% and the patient is comfortable with deferring further workup, you could potentially rule out the need to even proceed with that referral. Though again, like I said, any urologist that's doing things right will never be upset for having a patient referred with an elevated PSA. And of course, if their risk is above that threshold, then certainly refer to urology for further evaluation, which could then include MRI and or biopsy. And so with that, I thank you very much for your time. I've listed my email here. Happy to respond to any emails and look forward to discussing further here in the next several minutes.
All right, thanks so much, Dr. Tosoian. So that is it for our preset talks. We'll move on to the Q&A session now, and we'll have Dr. Wolf moderate that session for us. We have a few questions in the chat, so we'll start. I think Dr. Wolf has a question off the bat, and we'll start answering some of those other questions in the chat after we discuss this first one. Sure.
Thanks, Luke. And yeah, I'm going to take my prerogative as one of the panelists and a primary care physician. I recognize that in many parts of the country, there are shortages of urologists. And I suspect there are folks on the webinar who are in sections of the country with this issue. And so it gets to the, I guess to the issue, Jeff, that you touched on in terms of what else can we do besides just refer? So we can repeat the test, but once we've repeated it, the question arises, should we be ordering up the biomarker and interpreting it for the patient? And then I think the MRI question is a separate one, but should we be ordering the MRI? But maybe we could start with the biomarker. There was a question from the audience about how do we use biomarkers? And I think, because you just touched on this, Jeff, you mentioned that we should come up with a mutually agreed upon risk threshold that, if you get the risk level back from the biomarker, the risk of clinically important prostate cancer, that can be difficult with patients. And do some of the biomarkers offer like this is high risk, you should, meaning this is abnormal, you should refer, or can you talk a little bit more about that?
Yes, absolutely. So almost all of them do have a validated threshold, below which is considered negative, above which is considered positive, or high risk. The risk associated with a negative test for the tests that don't give the unique percentage to each patient is going to depend on that test's validated negative predictive value, right? So test with an NPV of 93%, a patient with a negative test will still have a 7% risk of clinically significant disease. But even the ones that provide a continuum of risk also have a validated threshold below which a test is considered negative, and the negative predictive value is kind of grouped for that entire risk spectrum. And so that is a big debate in the development and validation of these tests. Do we want a yes/no test? Most primary providers say absolutely. And yeah, so that exists for all the tests, with the one exception being Prostate Health Index 5. For whatever reason, their report still reads out 4 different risk groups, and it's still based on overall prostate cancer rather than clinically significant. And so, but the remainder all do have a validated threshold, and will say, this represents a negative test. The negative predictive value is 94% for this test, so the patient has a 6% risk of having clinically significant disease.
Great, thank you. And again, a similar question, perhaps with a different answer, perhaps about MRI. Why shouldn't we just order the MRI? What are the pros and cons? And I think this would be probably Pete, and maybe Yaw would weigh in. But
yeah, if you're in a group where the radiology and the urology team's preferences, I don't see any problems with ordering the MRI. But quality of MRI is a big issue. It's quite variable. And so not all MRIs are created equal. And if you go to, for instance, refer a patient to a radiology site that has no connection with a urologist, you may get sort of information that you can't use. And it's sort of a waste of time for you and the patient and everyone involved. The other consideration, though, is if you order it, you're going to be looking at a very complicated report that you may not be comfortable with, because it's going to have all kinds of terminology in it, PIRADS, and the patient may see it in their portal and ask you a lot of questions about it. So that's another consideration about whether to do that or leave it for the specialist to answer those kinds of questions.
Great. You all any comments?
Yeah, I think a lot of it also depends on your system, and where we are. You order a MRI, it can take 3 or 4 weeks for it to get scheduled, just because of access issues. And that scenario, I can say that if the primary care doctor orders it, at the same time they put in the referral, which may also, take some time for them to get in to see us, that allows at least the visit to be really streamlined when they get to us. So there's other considerations. But I think really at the end of the day, when it comes to the interpretation of the results, it really should be left to the urologist, and Jeff can attest to this, and Peter too. Sometimes even when the report says one thing, there's still more conversations to be had about, the interpretation of the result, whether or not those for us.
I know there can be great variability in how radiologists interpret PIRADS or interpret MRIs and assign PIRAD scores, right, Pete?
Oh, absolutely. It's any subjective scoring system is subject to inter-reader variability, and this is no exception. But, the good thing is that I think most people are solid on PIRADS 5 and 4. It gets messier as you go down, and it's more, but so that becomes, important to get a patient with a PIRADS 5 lesion to biopsy and therapy as soon as possible.
Sure. Well, great. Thank you. Well, we have a number of other questions coming in, and I can handle, or at least start on one of them. This is shared decision making needed after an elevated PSA. And what I would say as a primary care clinician is hopefully the informed and or shared decision making occurred before the PSA was ordered. Because once we order it, the cat is out of the bag. And so I think the key is to make sure folks know what they're getting into when you order it to begin with, because it's as we're talking about today, it's a chain of events that occurs, and some of the keys are they need to know that or they have to be willing to accept the possibility that if we work up an abnormal PSA and it's a low-grade cancer, that they're going to be living with cancer but not treating it. And that's an important point, in addition to the points about if they do have a clinically significant cancer, then the treatments can leave them with significant genitourinary and or bowel side effects. These are just some of the things folks should know, but that's before we screen. Once they've screened, I think really the shared decision-making issues come down the line with the urologist about how they're going to manage the cancer if it is diagnosed. That's my thought on it. Others? Okay, well, some other questions. This is about risk of prostate cancer conferred by long periods without ejaculation. I'm not aware that is a risk factor, so I think we're good there. And also, is prolonged or frequent bike riding a risk factor? And I don't believe that is. Can cause other issues, but I don't think prostate cancer.
I think it's important to talk about this because if you look in the literature, you'll find a lot of things that are associated with prostate cancer. Well, prostate cancer is very common, right? That's one of the things that I mentioned in my slide. So some of these associations may seem strong, but they're, you have a common disorder. A lot of people, for instance, let's take statins or vasectomy, right? A lot of people have both, so there's some overlap that's not causal. So those are really great questions. I think opportunity for us to dispel those, I almost said myths, not necessarily myths, but just those associations as causation.
Sure. Another question was about can significant dehydration and or overhydration affect the PSA level? I'm not aware, but maybe you guys are.
By my recollection, it's negligible. Any impact of hydration status has been found to be negligible on the PSA concentration. It's a great question, though.
Very.
Yeah.
And I think there was same with antibiotics. So you may see that as a PSA elevated because of UTI. And Jeff and I, trained and practiced after this era of antibiotics being given for an elevated PSA. But, that's also an association that's been debunked.
My father was given Cipro after his PSA came back. Of course, it shouldn't have been checked because he was in his 80s. He then got delirious from the Cipro. So yeah, no antibiotics to lower a PSA. Question about should biopsies always be fusion guided or not? I guess Pete.
So there are cases where the MRI doesn't show anything and the PSA is elevated and there's no possibility of guiding a biopsy. And so that's an obvious case. In general, I would say people are better served by some kind of guidance. If you get an MRI, use that tool to guide it. How you do that, whether there's the fusion device that fuses the images, but there's also so-called cognitive fusion for people who have really good eye-hand coordination, who can look at an MRI and say, okay, it's at this part of the gland, and I'll aim for that part of the gland. And I've seen results from those kinds of studies that are equal to fusion, but I would say that is not necessarily true for all operators. It's true for some operators, but not all. So in general, yes, I think it's a good idea.
Yeah, our guidelines recommend that if a patient's first biopsy was negative and was not aided by targeting, then consideration of a repeat biopsy should always come after an MRI. So the initial biopsy wasn't MRI guided. Certainly an MRI, should be performed prior to consideration of a second biopsy. There will be, cases where very high PSA that, it's thought by the clinician, by the urologist that it's better to just get to the biopsy, make a diagnosis so we can move ahead with treatment and get imaging in the weeks after the biopsy, because of the delays that can occur with biopsy or with imaging. So yeah, it's not required per se that, all initial biopsies, though NCCN says if available, should be used. The AUA is a little more liberal with that and just lists it as an option. Both MRI and biomarkers are options.
Right. And I think we've touched on this one, but it's the question about having an elevated PSA in the setting of BPH, and when do we consider the MRI? And I guess the question really is, BPH is so common, prostate cancer is common too, BPH is more common. Are there other things besides biomarkers and MRI that could help us? Should we be thinking about PSA density, or are we really relying on biomarkers and MRIs to help us, and then potentially biopsy to help us distinguish?
Yeah, my thought is, and we were talking about the MRI earlier, and I think the MRI, one of the advantages is it does several different things for us, right? So we talked about targeting, a lot of data to support that it helps us do a better biopsy, especially when there's a target present. But it also is up for us up front is really helpful with the decision-making process. Now, some would argue it's a very expensive way to find out how big someone's prostate is, but there's no doubt that we can factor that information into our decision-making as well, in addition to whether there's a lesion to target. And then for me also, I think about for those patients we diagnose, now they have a picture that helps us stage them up front. That's a very different value proposition than I think that our biomarkers offer us, which oftentimes is the yes, no. The MRI gives us a bigger gestalt and more options to sort of have shared decision making around whether biopsy or not. Where the biomarker, I find, at least in my practice, has helped me make a tougher decision of, okay, you've had a couple of negative biopsies and PSA is still high. Should we proceed? And I think as the data matures, maybe even higher, more upfront in the decision-making process. Maybe it's, and we argue about this at our meetings, but maybe you get the biomarker and then you say, okay, you should have a biopsy. We want to do a good biopsy. Let's get an MRI. So I do think that is going to continue to be the evolution of how we think about these. And we talked about shared decision making. I think Jeff and I have a lot of shared decision making conversations about, the risks and benefits of proceeding with the next step. So I know that Andrew, you and your colleagues are having really complex decisions and conversations about the whole patient, right? Which is hard. And then you send them to us and we talk, a little bit further about the prostate specifically.
Right. A big question here. How does the definition of an abnormal PSA test result change over age and demographic groups? How do demographic considerations affect the interpretation of intermediate PSA scores in the 4 to 10 range? So I think this is a toughie, but it's an important one. And love your thoughts on this.
I'll say just quickly, and then I'm interested to hear Jeff's comments too, because it was in my slide. So it does change over age. The younger you are, the lower the PSA. Remember, it's measuring prostate epithelial cells, activity essentially. And so prostates tend to be smaller in younger patients. And if there's a take home from today, PSAs under 1 are more of the norm for most men, and that's going to go up a little bit, not a lot as men age. So when we start seeing PSAs that are much above that, that's atypical. But atypical in the sense that we don't know if that's from enlargement or cancer, right? But it's not in the median range. As far as demographics, and I'm going to venture that this is a discussion about race, because we know Black males are more likely to be diagnosed with prostate cancer and more likely to die from prostate cancer. Numerous studies have been done in this arena. The best quality evidence comes from a group, a cohort that's called the Southern Community Cohort, that published median PSAs in the US. And they showed no difference in PSA levels once you adjusted for the higher rate of cancer. So some of the higher PSAs that you saw in the population simply reflected cancer patients being present and being a little bit more prevalent in the group.
Gotcha.
Jeff, anything to add to that?
Yeah, not really. We know that, PSA will increase with age. Yao showed some of those data that, and there have been published, age-specific PSA, what is normal, which, will go from 2.5 at a younger age to then 3.5 to then 4.5, usually with decades. Again, I don't think, anyone would ever criticize you for the majority of patients considering 3 and higher reason to send to urology. And in younger patients, lower levels, in patients in their 40s, even as low as 1.5 can be considered abnormally raised. But if you used 3 as a general approach, that's very reasonable.
Very good. Well, I think our time is up. I'm going to hand it back over to Luke.
Yeah, thank you so much, all of you. That was a fantastic discussion and super, super informative. Thank you to the attendees as well for all of your questions. It's really great when we see that kind of engagement. We are running a little short on time here, so I want to try and encourage you all to stay on the line until the very last minute because we have a few learning opportunities to share with you. But first, we do need to do that post-webinar poll. So Nyame will be putting that up shortly. We're going to give you probably a little less time for this one because we need to wrap up, but we'll give you a few minutes to look over these questions again. All right, thanks everybody for taking that post-test poll. If you're still finishing it up, please feel free to keep working, but we're going to move on just to make sure that we cover the last few slides here. The first one is sharing about Cancer Risk 360. This is a new resource from the American Cancer Society, and it's a web-based app that helps you assess your personal risk of multiple different kinds of cancers and helps you make choices and decisions about your health and your screening options for those cancers. Really easy to use. All you need is an internet connection and a web browser. So please be sure to check this out via the QR code or the link that we're providing here. Share it with your networks, your families, friends, anyone who wants to gain more insight into their own health and personal cancer risk. We also have another learning opportunity coming up for you that's very much related to what we've discussed today. We're launching an open echo. So this is a training program for primary care clinicians, and it'll be focusing on considerations related to prostate cancer screening in the primary care setting. It is open to registration by any primary care professionals. It's designed to support those professionals in navigating the complexities around screening. We'll be talking about things like how to identify appropriate candidates for screening, minimizing harm and overdiagnosis. Very similar to our discussion today, we'll be talking about interpreting PSA test results and when is the right time to refer a patient to urology. So this was a little amuse-bouche for the ECHO program that we're going to be launching in September. So please consider registering for that and coming to those sessions as well, which I should also add will have space for case discussion and peer-to-peer mentoring. So it's a great program, and I think it'll be of great interest to anyone who is interested in this topic today. We have our contact information here for the Prostate Cancer Roundtable. We are really just getting started, coming up to our first full year. We are going forward going to be knee deep, neck deep even in strategic planning for the next 3 years. So we're really starting to build some momentum, and we'll have more webinars, more resources, and more projects coming out over the next several months and well into the future. So please feel free to connect with us via these mechanisms here, especially the newsletter, which is where we'll be announcing things like future webinars and new resources. With that, thank you all so much. really appreciate you joining us today. Hope to stay in touch with you going into the future. Thanks again to all of our incredible speakers for sharing their expertise and their insights. And we will see you at the next one. Thanks, everybody. Have a great day and take care.